All right, thank you. So I set out, I don't have anything relevant to disclose. Actually, let me just mention, though, that even though I'm going to be speaking about the VA, I'm not speaking on behalf of the VA. Aaron says that too. All right. So what I originally wanted to do was to try to give an overview of what's actually happening out in the field in the VA with respect to integrated pain care. And just a little bit of a disclaimer is that it was really hard to find this out. And I guess one of the first barriers, I would say, to implementation, at least in our system, is just being aware of what everybody's doing. What are all the best practices? So instead, what I'm going to do is just focus on a few key examples, perhaps some what might be considered best practices or formative best practices. I'm also just going to walk us through a little bit of a timeline in terms of what's happened within the VA over about the last decade. All right, so just a quick definition, really, I'll just talk about integrated care and what I mean by that, a very broad term, but really what I wanted to focus on today were programs and demonstrations that were really multidisciplinary, where these programs interface with primary care and hopefully integrate with primary care activities. And I'm not speaking about integrative care, except that integrative care might be a component of integrated care, if that makes sense. So I'm going to just start off by presenting a couple of research projects that were both published in 2009 and that were really part of some of VA's more recent transformation in its pain management strategy. So the first trial is a study also led by Kurt Kroenke and his group, also known as the SCAMP trial. And this was a randomized clinical trial of a stepped care intervention for pain and depression among patients who have musculoskeletal pain comorbid with depression. And this was about half of the subjects were recruited in VA clinics and half in university clinics. And really to skip ahead to the end, because I really want to focus more on these real-life examples, this study showed that there were significant improvements compared to usual care in depression severity, reductions in pain intensity and disability, and patient-rated global improvements in pain. And again, getting back to some of that conceptual framework that Aaron was talking about, in this intervention that he studied, there were really three kind of key components. One is the notion of stepped care, namely that you start with a lower intensity, low cost intervention kind of more globally, and then if people aren't responding or there's additional complexity, you step up the care to more intensive interventions. The other key pieces were a nurse care manager who provided or facilitated an antidepressant optimization algorithm over 12 weeks, kind of walking through different types of antidepressants as needed, as well as providing pain self-management support. And the components of the topics that they were covering there are listed on this sheet. So another study, again, just to frame what's been happening in VA, was a study that our group did out of Portland, also known as CCAP. And this was also a randomized clinical trial of a collaborative intervention that was done at a single facility. And we had 401 patients and about 46 primary care clinicians. And again, skipping to the end, we found that there were significant but modest improvements in pain disability, intensity, depression severity, and also patient-related, our patient-reported global impressions of change. And just to show you a little bit about what that intervention looked like, which you probably can't see, we had a psychologist, care manager, who worked with a very part-time internist who really trained up for the role to provide decision support. The care manager would do an initial assessment of the patient and working with the pain specialist, provide feedback to the primary care provider and to the patient. And then she would follow up with that patient up to about 7 times over a 12-month period to provide additional self-management support and education. We also had a group session or a group workshop that we offered, and used a little bit of a stepped care approach in that patients might be referred to some of these ancillary services if they weren't responding or if they demonstrated a certain degree of complexity. So some of the lessons we learned from that project are that one is that many patients chose to participate in that study who also already felt fairly skilled in self-management. There were a lot of patients who seemed to feel like they already kind of got the difference between chronic pain and acute pain, that they needed to be relatively active. So I'm not sure we were really targeting some of the patients that we most maybe need to treat or really want to treat. And Dr. Dobscha can probably share some experiences with a slightly different patient population. Our group workshop was inefficient. Kurt Kroenke had warned me that it wouldn't really work, and he was correct. It really worked much better to have individual contacts between the care manager and the patient. Telephone worked great, but at least our group sessions for this approach didn't work. And clinicians were highly variable in their responsiveness and interaction with the collaborative care team. And this is something that you see across we've done one previous collaborative care trial, very similar. Some people are engaged. They really want to be partners with us. They want us to give them information, have them make changes, make the decisions. There are plenty of other clinicians who may be overwhelmed or not particularly interested, would be just as happy if we made all the decisions and just kind of took care of things. And that is a very real barrier that needs to be addressed. In addition, the intervention was somewhat expensive. And kind of skipping to the second bullet point, we had a full-time care manager who worked probably at the peak with about 180 patients. That's actually pretty good for a care manager. I know the numbers are typically lower for depression care. But, when you try to think about scaling that up to all the patients that we see who might have benefited from that, it was, at least at the time, considered cost prohibitive by our operations leaders in terms of trying to implement this on a more widespread basis. And we also had done an analysis looking at decay over time, and as has been seen with a number of these interventions, the effects do decay. At least they did in this project, which suggests that you really need some kind of ongoing or booster or some type of ongoing process to maintain effects. I'm not going to go into detail here other than to say in 2009, the VA did adopt this stepped care model for pain management. And really what it's saying is that at the lower levels, at the first level is really primary care and patient-based treatment. At the second level, you bring in consultants. And at the third level, then you may be looking at tertiary type care. So, so I'm starting to get into the context. So what's changed over the past 8 or 9 years in the VA? Well, one thing that has happened is the rollout of the TIDES program in VA, and what that is collaborative care for depression, which has been expanded a bit to alcohol use disorder, but probably about 8 years ago, the VA started putting some funding out into the field so that mental health divisions could hire care managers and to create a collaborative care type of system. I think there's still room that we have to go to fine-tune that, but that is in existence in many sites around the country. So there's kind of a collaborative framework or a collaborative care culture that's been developing. This is another model I'll come back to in a bit called Behavioral Health Lab, developed by investigators in Philadelphia. And in a way, it's complementary from the stepped care model. What happens in Behavioral Health Lab is that when patients have depression, they present with depression, maybe they're prescribed a new antidepressant, a health technician, trained health technician administers a series of structured instruments and essentially makes a triage decision at that point. So this is early in care. A triage is made with respect to this patient, whether or not they need to go to specialty care, whether or not they can use a collaborative care model, or perhaps maybe just a little bit additional support from primary care with even watchful waiting. The other thing that's happened in the last 10 years is introduction of the patient-aligned care team model in the VA, which is VA's version of medical home. That's still very much a work in progress. We've also had developments in e-health. So one of the things that's occurring fairly widely now is clinic-based telehealth, so clinic-to-clinic telehealth services, which helps expand access for rural veterans, especially to specialty care. We are just getting rolling in some ways on video-to-home services, really being able to beam into veterans' homes and provide the care there. And we have developed an electronic health portal. It's known as My Healthy Vet, and secure messaging processes. And we have an app store, and we're just getting rolling, I think, and trying to disseminate a number of apps that have been developed to promote self-management. And then the last thing I'll say about context is about measurement. In 1998, VA did adopt pain as the fifth vital sign. And so the 11-item numeric rating scale continues to be administered at most ambulatory visits. This is a measure of pain intensity. We have had discussions about changing our pain measure to include measures of function and quality of life. There's been rumors about trying to use the PEG, but unless Aaron knows something that I don't know, I don't think it's going to happen. We've certainly done additional research to try to gather more patient-generated data, but there are considerable IT barriers to gathering patient data in the VA and getting that put into the electronic health record. And the only thing I'm going to say about the opioid crisis, since everybody else has been talking about it, is that we do have a couple of risk prediction tools. There may be even more than this, but the two that are probably best known are STORM and the Opioid Therapy Risk Report. And these have been developed in the past few years and really provide a population base. It's kind of a panel management tool. And I don't think the uptake has been that great at this point into routine types of practice. So recent examples. The psychologist, so as part of the whole TIDES rollout, we've embedded a number of psychologists in primary care. There are a number at different sites who are familiar with TIDES principles who are actually doing pain care now. And so they're assisting with assessment and consultation and can integrate pain approaches with their mental health approaches. Many have had training in a VA program called CBT for chronic pain, and some preliminary results suggest that that's it has had positive impacts. And so far, over 500 VA clinicians have been trained in CBT for chronic pain. So there is kind of this slow rollout, and in a number of sites, you do have some co-location of people providing pain services. One of the programs I wanted to mention was the Integrated Pain Program, which is in West Haven. And there are probably a number of programs like this around the country. I just learned that the San Francisco VA has something similar. They have really two parts to that program. So the first is a half-day per week clinic that occurs within a primary care clinic. And they do a one-time assessment, but also do some nurse care management follow-up to see that recommendations are implemented. Some patients, the higher risk ones, will get referred to an opioid reassessment clinic. This also takes place for a half day a week in primary care. They add to their team some addictions expertise. And in contrast to the integrated pain clinic, they do some longitudinal follow-up and really take over some of the opioid prescribing for more of the higher risk patients. And because I'm running out of time, basically some initial outcomes that Dr. Becker has written about would suggest that the program is being fairly successful, increasing rates of urine drug screens, decreasing overall doses of morphine equivalents, and helping people getting engaged in addictions treatment. Getting back to this behavioral health lab model, one of the things that the Philadelphia VA has done is to expand its collaborative care arm, which is the one on the right, to when patients have comorbid pain with their depression and other mental health conditions, they will add acute and chronic pain modules They will conduct additional motivational interviewing. They have patient-centered workbooks and supplemental education, pain monitoring over time, and still do all the other things that you'd see in a traditional collaborative care approach. And I talked to Amy Hellstrom, who is she's got a paper under review right now, but in this study they compared people who had been randomized to that chronic collaborative care plus pain versus traditional collaborative care, found that in both groups there were improvements in pain outcomes, but that no differences between the groups. A couple of barriers that she noted. One is engaging patients in the biopsychosocial approach, and also keeping clinicians up to date on the program and the model and its goals. And I've also found that to be a universal problem or challenge. One more demonstration I just wanted to mention. Nancy Wiedemer, also in Philadelphia, has had an opioid renewal clinic going for over 10 years now. This is a PharmD embedded in the primary care clinic, who again ends up taking over opioid prescribing for very high-risk patients, or the higher-risk patients. And in an evaluation that they've done, they again find greater adherence to opioid treatment agreements, a number of patients being referred to addiction services who need it, more use of urine drug screens, et cetera. A couple of barriers I would mention that she reported is one, the PharmD can't actually write in the VA system for the prescriptions. I'm not so sure this is a bad thing because it probably keeps the primary care providers a little bit in the loop. I think that she notes a lack of resources for non-pharmacologic treatment options. This is definitely something you see across the VA. It seems to be getting a little better, but as Aaron noted, there are many, many hurdles, often just to figuring out what resources there are that you could refer to and how to get them there. I think I'm going to keep moving here. I just wanted to mention briefly that there is more. This is a slide I borrowed from Kurt Kroenke. These are all trials that his group, and you'll notice scope is on there, space is on there, kind of all built on this collaborative framework that are either completed or in progress. So a lot more research has continued to be generated about this framework. I'll mention Ben Marasco still has an ongoing trial right now, which is using a collaborative model to enhance opioid safety in primary care. So it's more focused. It's definitely a collaborative care model, but it's more focused on opioid safety issues. And so they do assessments, have discussions with the veterans about safety concerns. They track opioid-related events, make sure people have opioid treatment agreements, they get regular urine drug screens, that the PDMP is being used, and so forth. That study's still in progress. So where are we in the VA? Well, the positives, so we certainly have a number of interesting demonstrations and programs going on. There's a lot of activity about integrating pain treatment within primary care, and these programs are often treatment or team-based. The not-so-positives is that many of these sites don't have these components. I don't know of anything out there where people are doing the full meal deal. I think Philadelphia is the one that I can see that has many of the components, in particular the pain monitoring piece that their collaborative care program does. Measurement-based approaches in general, I think, are really holding us back. VA is not alone in this, but as I look forward to the next steps, I see that's where we really need to fix that problem and how to integrate measurement into our regular practice. I will mention also that there's a lot of challenges that primary care providers have in light of competing demands. VA has a tremendous focus on access right now, and that's another key issue, as well as ongoing challenges in accessing non-pharmacologic treatment options. So I better stop there, even though I had one more slide. Thank you.